In the last lecture, we talked about the oral health promotion programs that already exist within communities. I concluded the videos by challenging you to think about these programs and, as future dental health professionals, expand or alter these programs in the most beneficial way for our community members. This last lecture, yay, is to give you the proper tools and how to develop these programs. Some of this information is going to look pretty familiar to you as we discussed a lot of it in oral health education class last spring. So some of this is going to be a refresher for you. However, I want to focus our discussion on utilizing the dental hygiene process of care in creating oral health promotion programs as opposed to oral health education programs. Because of that, there is some very unique and new information that is pivotal to oral health promotion programs that is going to be highlighted in this final lecture. So we're going to revisit the process of care. So we're going to go through the assessment, diagnosis, planning, implementation, and evaluation phases, and then we're going to wrap up the semester. So, want to bring your attention back to the dental hygiene process of care and the diagram that the ADHA developed in 2016. So you can see how the assessment, diagnosing, planning, and implementation and evaluation phases look in conjunction with one another. And at the center of all of this is our documentation. So we're documenting throughout each particular step of the dental hygiene process of care. So in this particular video, I really want to highlight the assessment phase, because if you recall from oral health education, the assessment phase is the most critical phase of the dental hygiene process of care, simply because we're collecting the data and it's going to build the backbone or the foundation of everything else that we're going to do within our oral hygiene, oral health promotion programs. So recall what an assessment is. It's that systematic approach to identify the population or the needs of that population, as well as the resources that are within that community. So we really want to get a feel for what the community and the people and the community are like and what their needs are, because every single community is going to be different. And Marcia Deaton highlighted that on Tuesday when we were talking about the health departments and the dental hygiene programs and the public health dental hygienists that are associated with the health departments. Each health department is offering something different to the population within their community. And hers in particular was offering not only education and prophies, but sealants and fluorides. But other health departments weren't offering all of that. So why do we do an assessment? Several reasons. If you recall, we need to know the problem and we need to know how severe it is within that community. We don't want to do anything that is redundant, and we want to focus our efforts in something that is going to be applicable to the community members and something that's going to be beneficial to them. As we talked about in oral health education, there are lots of problems within communities, so we have to really kind of narrow our focus in terms of our interventions. So one of the things that we have to narrow our focus on is identifying a target group. So, educating and doing oral health promotion programs for an entire community is just a little bit too much work to do, honestly, and it requires a lot more resources. So we're going to have to kind of target different groups within the community for our interventions. We need to collect that baseline data. So once we have that baseline data, then we can compare the data at the beginning to the data that we collect at the very end so that we can determine how effective we were. Not only are we comparing to the end data, but the baseline data is going to allow us to be able to identify what the needs are and the severity of them. And once we figure that out, we can go through that whole diagnosing phase. We can start writing our objectives, and we can start actually developing not only our intervention, but how we're going to evaluate at the end of the day. So what do we measure? We want to know about the population. So depending on kind of our thought processes and what we have available to us, we'll want to know about our population in terms of how many people are within our community and what are the ages looking like. What are the racial and ethnic backgrounds of the people within the population? What is their general health profile? Certain diseases are prevalent that you may need to focus on, and the connection between the systemic and the oral health between those. We may want to look at diet and nutrition of that community, especially if they're in a food desert. We'll want to think about employment so that we can start thinking about things like insurance profiles and whether the community members have discretionary income to be able to access dental care on their own or not. We'll want to know some more epidemiological types of variables such as their income. So you have to think about socioeconomic statuses and epidemiological rates and utilization rates whenever you're talking about income and educational attainment. And then we also want to talk about transportation and all those barriers that may be impeding people from utilizing dental services as they are already presented within that community. We want to think about the epidemiology of the diseases within that community, and we can go back to the data that are presented and collected by state public health officials and the CDC and those type of things. So we want to look at the epidemiology. Are root caries the problem in a certain population, or is it more perio, and how frequent is that? We also want to think about existing programs that are out there. We want to supplement these programs. We don't want to duplicate it because that's just a waste of our time and resources. So we also want to think about the programs that were put in place and that actually failed previously. We want to know why they failed so that we don't make those same mistakes. We want to know how the community members perceive these programs. Do they accept them with open arms, or are they a little suspicious of it? We want to know who's responsible for administering what's currently out there so that we can actually work together and be allies. We want to know community leadership. We talked about community leadership when we talked about community water fluoridation and how once you get your professional organizations on board and that you have power in numbers from like-minded people within your profession, then you go to the people that are in charge. So who are the community leaders and what are their attitudes towards oral health? Do we need to educate them about oral health issues so that they will be empowered to hopefully make decisions on behalf of their constituents? We also want to think about the human element of things. So the participants in particular, we want to know what their perceived needs are. What do they think that they need? We want to know the demand for these programs. We want to know their attitudes towards these programs. We want to know if a barrier is the access to care. in their community, our dental offices typically only open during certain times, which is bad for the majority of the people within the community. Is there transportation issues? Is there any issues in terms of the practices that are out there taking your type of insurance? So we need to know all of that. We also want to know about the dental utilization rates, and how often they're going, and what are their attitudes regarding that as well. So we also need to think about resources that we have. That's a major component of doing an assessment, because you might have these grandiose ideas, but if you don't have the backing or the funding or the resources, the manpower to implement it, then you're going to go nowhere. So one of the major things is money. Is there any money available? Is there a third party coverage available through the community, through workplaces, or are most people on Medicaid where you can bill out Medicaid? Is there any federal funding money available, or do you need to go to private industry to get some grants, or get some donations? So there's two different ways that you can get money. Typically in public health, you're writing for grants, meaning you're writing for either to the government or to a private industry to give you money to fund your programs. And there are two different types of grants. There are block grants, and then there's line item grants. With a block grant, basically what you do is you write up a proposal, you tell the people, either the government or the private industry, what you want to do. What's your idea? What's your idea for the oral health promotion program? And basically, if you're awarded a block grant, it means that the industry, the private industry or the government, gives you a lump sum of money that you can use at your discretion to build your program. So you don't have to say, I'm going to buy light cures and my sealant material costs X amount of dollars. You know, they don't care about kind of the nitty gritty details in terms of doing block grants. They just want to know the bottom line. How much do you need? Is it kind of justifiable? And if it is in their mind, then they'll give you a lump sum. Line item grants, on the other hand, is when you write your proposal, you have to go line by line by line in terms of what things are going to cost. So if you say, I'm going to need 10 mobile chairs, and I priced them at this particular company and they cost $100 each. So I'm going to need $1,000 for mobile chairs alone. And then the next line item would be, I need sealant material, and this sealant material has the etchant built in, and we are, it costs X amount of money, and we need 100 tubes of sealant material. So you really have to be very specific whenever you're doing a line item grant, and then they'll fund the your project either fully or partially, depending on what's in your line items. In terms of resources, not only is money very, very important, but you also need to think about your facilities and your labor. So it is where you're going to do your oral health promotion program. Is it accessible? Is it at a good location for you to be able to actually implement your oral health promotion program? And do you have the manpower? Do you have to have dental personnel? So is it a very specific oral health promotion program where you are doing clinical work where you'd have to have dentists and dental hygienists, or are you doing a fluoride varnish program where you could do school nurses or other public health officials? So you have to kind of think about all of your labor cost and if you're going to pay them or if they're going to be all volunteer based. Some other things to measure: your fluoride within the community, what's going on with your community water fluoridation. And if you don't have community water fluoridation, are there any other caries prevention programs in terms of fluoride that are going on, like mouth rinse programs or varnish programs? So, types of data that you collect during the assessment phase, there are two different types. There's quantitative type and then there's qualitative type. Your quantitative type is a very objective data that's going to be measured. And typically, my rule of thumb of how to distinguish between qualitative and quantitative when I was especially a new student at all of this is quantitative is associated with numbers. So you have a number that represents the size of the problem. So examples are your incidence and your prevalence, or your plaque scores, your percentages, your DMF scores, even a lot of your indices that are ordinal based. We have that number associated with them that defines the severity of the problem. Qualitative data, on the other hand, is data that really is rich with words and explanations. So that data really kind of reflects the quality of things that you can't really put a number to, and you can't data crunch it. So qualitative data really kind of helps explain why a problem exists or why people have certain attitudes towards dental care. So, an example of this is we might go and interview people that don't utilize dental services as to why they don't go to the dentist. Some other sources of information. Of course, not only are we going to ask the people, and we'll talk about that here in a second, but we're also going to comb the literature. We are going to look at existing information that's out there. So we're going to go to our journal articles that are evidence-based and peer-reviewed and see what researchers have found previously. We're going to go to our oral health surveys as well on a national level as well as a state level or even a community level, and we're going to look at that. For instance, Smile Kentucky in its heyday, it really was based on the fact that Kentucky had a really great survey on kiddos and followed up with adult information throughout the state in the early 2000s. And that was how Smile Kentucky really was formed, was that we found in Jefferson County and surrounding areas that about a third of the child population was really struggling with dental caries. So that was the basis of Smile Kentucky and getting it off the ground, basically. We can also look at the Census Bureau. The Census Bureau gives us great information on income of different places, as well as the educational profile and the population numbers within a community. And then, of course, we can always look at dental records and charts as well. We can go to community agencies and get some information from community agencies, such as the dental and dental hygiene societies. Sometimes that they'll give periodic surveys in their region. They also have a list of professionals. So the Kentucky Board of Dentistry has a list of dentists, practicing dentists and dental hygienists that you can purchase, actually. So you would have a whole list of all all the dental hygienists and all the dentists within the state of Kentucky, and then you can hopefully enlist their help. You could go to the Chamber of Commerce, which houses a lot of employment information, such as a local organization of businesses and who might be helpful in your enterprise. You can look at voluntary health agencies like American Cancer Society or the Kentucky Cancer Program or the American Heart Society. And then maybe you can pair up and team up with them. Or maybe they actually have some research on your area of interest. And then, of course, universities are always great places to partner up with as well. We also want to really get information from the participants themselves. And we talked a lot during oral health education how to conduct surveys, whether they're written or they're oral. When you conduct surveys, they're really useful when you really want to know about what a person's oral health knowledge is, what their behaviors are, what their value systems and their attitudes are. You can't necessarily assess kind of their clinical basis and how they perform certain skills in terms of surveys, but you can know what their knowledge is. But remember, their knowledge and their attitudes doesn't always translate into behaviors. A written survey is really great for large groups. So if you have a large amount of people within a community, probably your best bet is to do a written survey as opposed to doing kind of those oral interviews. And then we can always conduct focus groups, which we also talked about in oral health education. Another thing that we can do as opposed to conducting surveys and getting the knowledge and what the people tell us that they do at home and how they value things is we could do clinical screenings. And this is where we actually screen people to determine the need of the community. So we can get the oral health status of the community, and remember, need is defined as a professional opinion or a professional behavior or professionally defined is what I'm trying to get at there. I don't know why that escaped me, but it establishes those dental needs, which is professionally defined. So just to refresh your memory, the difference between exams and screenings: exams are much more thorough overall, and screenings are very quick assessments. And basically, we're not being really nitpicky with a screening. We're just identifying gross needs overall. We don't get as much information as we do in exams, but they're also really a lot less expensive and quicker to perform overall. What is essential to know is that neither the exams or screenings, when you are doing oral health promotion programs within the community, we're not really including services other than awareness of needs at that point. So it's really useful in research, for research in terms of gathering up information on health statuses of the community. So this is something that is unique to oral health promotion programs, is the different types of clinical screening classifications, and these pop up on boards all the time. So this is something that I would really try my best to understand the differences between a type 1, type 2, type 3, and type 4 clinical screening. I would earmark this for board preparation. So my rule of thumb is to know that a type 1 is the most comprehensive thing that you can get. And as we go down and get higher in the numbers, the less extensive the clinical screening gets. So a type 1 is really more of a comprehensive exam where you're utilizing your mirror, your explorer, you have radiographs, and oftentimes you have a full mouth series. You may even do impressions and do study models. You may be doing pulp vitality test. So you're really working up the people within the community by doing a type 1 clinical screening. They are very time intensive. They are very expensive to conduct. And you have to have a lot of manpower. So we rarely use a type 1 clinical screening in public health because of that. A type 2 is a little bit less comprehensive than a type 1. So you're doing a limited exam as opposed to a complete exam that you do in type 1. So you're using a mirror, you're using an explorer, and you're actually, instead of having a full mouth series, you may just have a bite wing or a pano of that particular patient. So this is not done as often due to x-rays. You can also have selected PA radiographs as well. So it's not just limited to posterior bite wings, but you're just not having the full complement of radiographs with a type 2. A type 2 clinical screening is very useful if the program includes services to the individuals. There is a program out in the United States called RAM, Rural Area Medicine. And we used to participate in RAM a few years ago, and when I was a student. And basically, RAM is a pretty comprehensive setup. And a lot of times it offers dental services to the community members. And it could also include like eye exams or blood glucose and diabetes screenings. It really kind of depends on what's going on in that community and what that community needs in terms of services. But in terms of the dental part of RAM, what happened was is that people would come and line up for days before a RAM hit town. And they would line up middle of the week, and then services would start being provided early Saturday morning, and volunteers would provide dental services all day Saturday and part of the day on Sunday. Sometimes they would even put Friday in there. It would be a full weekend thing. So those people that are lining up for dental services, they actually get screened, and the people that were doing the screenings were the dentists. And they would do type 2 screenings. So some of them would actually get pans or even bite wings done, especially if they had oral surgery needs. There was an oral surgery component to RAM where they would do a lot of extractions. So typically there were 3 parts of the dental part. So you would do mass extractions. The dental students would do not only the extractions, but they would also do the fillings. If the tooth could be saved, they would do fillings, and then we would have dental hygiene students go and provide hygiene services. And a lot of times it was like, that was the most calculus that you may ever see. It was pretty gross debridements as opposed to, your typical prophies that we do within clinic. But the point of all of this is to say that we were providing clinical services to individuals through this oral health promotion program called RAM. And we were utilizing a type 2 screening for each patient that would come through so that we would know what their needs were, and we could direct them into the most appropriate section of the dental services. A type 3 is a little bit less comprehensive than a type 2. So you're utilizing a mirror, you're utilizing Explore, and you have adequate light. So this is one of the more common ones that we're seeing within the public health settings, because you're actually getting in there, and you're looking in there, and you're seeing what's going on. It's almost like what we did with family and friends, because we're not doing radiographs or study models on, or pulp vitality tests on family and friends. We were just getting in there and doing some of the assessments and then scaling a little bit. So almost similar to family and friends, but a little bit different than what we did with family and friends. And then type 4 is our basic rudimentary type of clinical screening. We just have a tongue depressor and we have light. So we're just really going in there and looking at the oral cavity, kind of peering in there and seeing if there's any gross needs that we could identify. So is there a big bombed out tooth over in the left quadrant, or is there like a big abscess going on? It's really only identifying very obvious gross needs. Type 4 screenings are becoming very, very common within public health, especially when we are gathering data for surveillance and we're utilizing those non-dental personnel, such as the public health nurses and our public health officials doing fluoride varnishes and that type of stuff. So type 3 and type 4 are the most common within public health, simply because we can go out into the community and we can actually utilize these types of screenings fairly easily. So this concludes the assessment phase of oral health promotion programs. The two biggest, newest pieces of information that are unique to oral health promotion programs are the different types of grants that we have and how we fund our oral health promotion programs, as well as these clinical screening distinctions between the different types. So type 1, type 2, type 3, and type 4. So in the next video, we're going to talk about the diagnosing phases of oral health promotion programs.